Well, hello, friends, and welcome to another installment of Kidney Talks with the George Washington University Ron and Joy Paul Kidney Center. I am your host, Reverend Dr. Kendrick Curry of the Pennsylvania Avenue Baptist Church in Washington, D.C. And we are also partner with the GW Ron and Joy Paul Kidney Center, as well as MOTEP, which is the Minority Organ Tissue Transplant Education Program. We're excited today because we're going to have a wonderful presentation on minority donation and community outreach by Mr. Kenny Boyd, who is from Infinite Legacy, and he's the vice president and chief benefits, chief business development officer at Infinite Legacy. And so we welcome him right now with a wonderful presentation.
Thank you, Dr. Carey. I appreciate that. And if I can get that presentation brought up, and thank you really quick. Infinite Legacy is a federally designated organ procurement organization. We service 68 hospitals and 8 transplant centers in the DC metropolitan area. So our service area is the entire state of Maryland, Northern Virginia, and the District of Columbia. And again, we're a nonprofit, federally designated organization. We serve a population of almost 10 million people. And so those 10 million people are relying on us to be that bridge to hopefully life and restoration that organ donation and transplantation brings. But today I want to talk about the importance of community outreach. We know that disadvantaged communities tend to donate at a lower rate than some non-minority communities. And so Infinite Legacy, through the work of one of our very talented directors, Miss Aisha Johnson, came up with a really novel approach to address it at a grassroots effort, and it was titled the Decision Project. So I'd like to just share Aisha and Infinite Legacy's work with you all today. I had a video here, but I'm unable to show it, but it kind of gave some sound bites about why minority communities were hesitant or chose not to speak about their donation opportunities or decisions. And essentially, what it says is we don't really have enough information to make a decision. We don't trust the healthcare community, and we don't feel like donation benefits us. So the Decision Project was really shaped to address those specific concerns. And the Decisions Project is a grassroots initiative. It aims to educate, empower, and then inspire communities, disadvantaged communities, underserved communities, into making a decision that could save a life. We tell those families that you have the power to save lives, and the decision is theirs. So when they were looking at this, I think that they took a very deliberate tact. And the first thing they did was to review donor designation rates and wait list candidates within zip codes in the city. So they wanted to look at, from a specific community, how many people were registered, and in that same community, how many people were on the wait list. So were we meeting the need of those people from within that same community? Once we had that data in hand and we realized there was a great disparity, so there were a lot of people in a specific zip code who were waiting for a transplant, but not a lot of people from that same zip code who were registered donors, we sought guidance from the local health department and an area hospital, Sinai Hospital, because this took place, the initial launch of the TDP took place in a Baltimore community. And so once we got that information from the Department of Health and Sinai Hospital about that community that they served, we formed a task force. And we talked about how we were going to address it. And so this is the zip code 21215 in Baltimore. And you can see this might be a little bit small for the people online, but you can see the highest zip codes in Baltimore in terms of people waiting. And 21215 had 80 people from their community who were waiting for a transplant, or almost 80. But their donor designation rates were 54% lower than the rest of the state. So there was a clear need in their community, but people did not either identify that they had an opportunity or chose not to, or had a lack of education about that opportunity. So our goal was to address that. We wanted to find out what are some of the common reasons why we're not getting authorization. So the first thing we did as the organ procurement organization was looked at our data and looked at why we're not getting authorization from that community. And we found that overwhelming, it was general mistrust of the medical community and not a lot of information about organ, tissue, and eye donation. So we wanted to look at some of the contributing factors that uh, were motivating these attitudes towards donation in healthcare. So within that zip code, we recognized that 50% of the residents were raised by single parents. One third of those residents only had a high school education. Half of the residents were unemployed. There were more than 2,000 vacant buildings within that landscape. So you can imagine how that impacted the visual environment that they were in. And the median income was $7,000 below the rest of the city and 26,000 below the regional median. So it's truly a disadvantaged community. So we recognized that there was an opportunity to make some change. We wanted to do that both from the historical context of the community, and we sought support from Baltimore City Council to do this. We looked at support from minority community leaders within the hospital systems that service that community, and then we would organize focus groups to address that target population. We also began to attend social advocacy meetings because we needed to understand the community at a deeper level in order to meet them where they were at. So the one thing that we did as an organization is understood that this was going to take time. This wasn't a one weekend event that we would interact with the community, support them on an initiative, and then expect them to change their attitudes about donation. That we were going to have to do some work, I like saying sweat equity. And so we set out with that understanding, and we worked with city council support. We had our community leaders, whether they were faith-based, or other entities. We worked with the neighborhood associations, local law enforcement. Again, our pastoral support was important. We plugged in with the hospitals that were surrounding that zip code. We worked with the food bank. Tons of families in this area have food insecurity. And so, how can you hear another message when you're hungry? And then we began to utilize events like annual block parties and gospel fests to bring the community together. And bringing the community together, we were able to offer screenings for any health related issues or concerns, as well as provide the food and connecting with other social support. And that helped us to kind of ingrain ourselves into the community. So this information is about the focus group that took place from 2018 to 2019. And so this was based again on the 21215, and we were able to identify those challenges within that group, and then use that to replicate the TDP in a second zip code, which was 21205. And these are some of the sample questions were really based around understanding what types of engagement they would participate in, what myths and misconceptions were driving their feelings about donation, what were their barriers to saying yes, and then coming up with targeted messaging and strategies to close those gaps. So these are the common themes. It's just a lack of knowledge, general mistrust, how organs are allocated, meaning there's a concern that organs were being redistributed from their community to more affluent communities. The consent process, not feeling like they would always understand. We remember back to the first slide, and we looked at only a third had completed a high school education in that zip code, many unemployed. Eligibility, didn't know they could be a donor, and then just transparency of that donation process. And so we took those common themes and began to address those. And we did it in the structure of a SWOT analysis, where we looked at what our strengths were as an organization, what the weaknesses were in terms of reaching out to the community, and then identified our opportunities and paid close attention to our threat. So we knew at our strength that we had a commitment to the community. That message just wasn't penetrating down to these zip codes with the low donation rates. Our weakness was just human resources. We're a not for profit, and we knew that this was going to take a lot of sweat equity, a lot of people on the ground. We also had to be really careful as an organization about the regulatory environment and how we could allocate our funds. But altogether, we saw that as an opportunity for us to reach out to the community and improve to support them. There were some threats in Baltimore in this 2125 area code because it was serviced by John Hopkins. And we know that John Hopkins has a kind of complicated relationship with the Baltimore community. And so when we talk about rebuilding trust, a lot of work was needed in that area to rebuild trust so that families could still hear the donation opportunity. I think at organ donation, since it takes place in hospitals and we collaborate with hospitals to facilitate that, we share whatever feelings the community has about the hospital. So we had to pay attention to that as we move forward with the TDP. And so the lessons that we learned throughout this process is we weren't prepared for the mistrust, especially with what they had with John Hopkins. And maybe we should have. I know there are more public stories, but historically in that community, generational history about that relationship with John Hopkins was a great barrier to families saying yes to donation. Internally, we recognized that we needed to make sure that our teams were aware of the concerns within those community. So these abbreviations, HS and FS, that's our hospital services team, the people that work with our healthcare professionals to educate them about donation. And FS team is our family services providers who work with families and offer them the option of donation. We needed to better equip them to meet the needs of that community. You can only offer an option effectively if you understand who your target audience is. And then we learned that, again, it would take time to work and build trust, and not months and not weeks, but years, and that you had to sustain that. So we couldn't ever walk away from that. COVID taught us that because COVID limited the amount of community activities that we did during that period. And what we saw is our donation rates and our donor designation rates had dropped in those zip codes again. And so now that COVID has wrapped up, we're back out there on the ground, back interacting with that community to assist them. So our strategies and tactics to anyone who wants to replicate this is to continue to build a strong community presence, frequently guiding, letting the data guide you, working closely with our internal teams because they're also our messengers, engage and empower our community, but especially high school students. Never miss an opportunity to correct mistruths or to debunk the myths. Share relatable stories. That means if you have a recipient in that community or donor family, you need to bring them back to that community to be the messenger. And then we wanted to overall improve the donation rates in that Baltimore City. And we were able to do that within that zip code, 21215 and 21205. And so what I would encourage anyone who wants to get more information about this is I would put you in contact with my Director of Community Affairs and founder, creator of the Decision Project, Ms. Aisha Johnson, who can be reached at the web address below. And that's it, Reverend Curry. I'd be happy to answer any questions.
Well, I do want to just thank you. And before we go into the questions, I do want to greet our co-host, Dr. Joseph Keith Melanson of the George Washington University, Ron and Joy Paul Kidney Center, a premier transplant surgeon in our nation. Mr. Boyd, I was in very much appreciate your talk and the work that you've done. If you could explain to our viewers how you came up, or how you all came up with your theory of change, of how you were going to make a difference.
Yeah, I think. Well, the first thing is I think we were humble enough to do the work to look at to where the data would point us.
Mhm.
So, as an organ procurement organization, I think we're constantly reviewing data to see where our performance gaps are. We want to meet the need of those 100+ thousand people on the national wait list, and so we're looking for our gaps in our performance. And what we realized is we weren't meeting those performance goals when it came to authorization. And so
Mhm.
we have the ability to look at two pieces of information that will guide us towards where that performance gap is. One are the donor designation rates, the number of people who have decided on their driver's license or through a donor registry that they want to be a donor. And we can sort that data by zip code.
Mhm.
The other thing that we did is we looked at the number of recipients waiting in our service area, and then again by zip codes. And so what we did is we compared that number of people waiting in a zip code and looked at the registration rates in that zip code and realized that there were gaps and there's opportunities to improve the numbers. I think one of the slides I shared earlier showed that the donor designation rate in that target zip code, Park Heights and Baltimore, Maryland, was 54% lower than the rest of the state. And so they weren't in a position to even meet the needs of their community when it came to people waiting in that same zip code. And so that guided us towards here's an opportunity to ask questions about why. Why is that choice to donate 54% lower than the rest of the state?
Sure, sure. And I did hear you talk about, where there was limited information, folk didn't have enough information to make decisions. There's mistrust and distrust. Could you speak to the depth of the distrust in the community that you have experienced?
I think it is present in all underserved communities, and I think the African American community has several historic examples of why we have mistrust of the medical community. When we look at the Decision Project and addressing the needs in this Baltimore community, John Hopkins is one of the hospitals that is serving Park Heights, and especially for the patients that represent a potential for donation. So these are going to be trauma patients, victims of car accidents and crimes, and needing a high level of care. They're more than likely going to go to John Hopkins for that high level of care. And John Hopkins doesn't have the best reputation in that community for several reasons. And maybe Dr. Melanson, not to pull him into this conversation, but could speak on some of the things that have contributed. But we can talk about Henrietta Lack. We can talk about urban myths of Hopkins physicians knocking on doors in the community looking for patients to care for. And so there's a general mistrust of the hospital. And if you feel like if you go to the hospital, you're going to be the subject of an experiment
Yeah.
or not treated properly, then you add in donation. It's like, well, if I go to Hopkins, are they going to take my organs? Are they not going to treat me so they can have my organs? I think that those are huge contributors to people's perception of donation and impacts how they respond to that opportunity to donate.
Yeah. Dr. Melanson, any comments with regard to this whole piece of just the mistrust of medical profession? It not only its origin, but what we see locally and how it continues to persist generation after generation.
Yeah, thank you, Reverend. And first of all, I want to say that I've worked with Kenny Boyd for many years, and I know that he has been a force in the community, working against a lot of these misconceptions. But I must be honest and say, although these are misconceptions, many times it's rooted in truth. And he's so correct in talking about Baltimore in particular, um, for years, and this goes all the way back to the very beginnings of Johns Hopkins, there's been this long history of enrolling Black people into research studies without consent, and this has persisted for generations. And so the community has long had a distrust of that institution. And then comparing the two downtown Baltimore institutions, University of Maryland and Johns Hopkins, again, Maryland has had a long tradition of having one of the best trauma programs in the world. And so many people have had positive experiences of going to University of Maryland for their trauma care, and therefore I think Maryland benefits from that good feeling in the community in regards to trauma and trauma care, and positive reflections of minority physicians. Maryland has traditionally been more diverse than Johns Hopkins. So I understand what Kenny's talking about when he says that anyone that's involved in organ transplantation in a community, the hospital where the procurements are going to occur, where the transplants are going to occur, the history of that hospital in the community is going to be very, very important. But I do have another question for Mr. Boyd, and
Yes, sir.
that is, you know, right now the entire transplant community are we're having issues with negative impressions because of media coverage of various occurrences in our own backyard. Number one being, UNOS, the United Network of Organ Sharing has just gotten black eye after black eye, primarily because there is an impression in the community that they are, mismanaged to some degree. And I believe that I know that has affected what I see in our transplant program. That's number one. And then the organ procurement organizations, and this really ramped up during the Trump administrations, where the Trump administration really put a bullseye on organ procurement organizations and them underperforming. I'm just wondering, in both of those instances, have you seen mistrust go up in the minority communities? We know it's gone up in the more elite, rarefied areas around Washington D.C., where there's so many very highly educated and erudite individuals. But I'm wondering, have you seen this at all levels of the community, that this attack, again, not necessarily non-merited attacks, because I think there is room for improvement in both organizations. But have you seen an increase in scrutiny in the minority communities as well?
So, simple answer is yes. And I think so. And especially remember, Infant Legacy covers also District of Columbia and those surrounding counties where there's a higher prevalence of hypertension and other diseases, which means there are more people waiting on the list. They're realizing they're waiting longer on the list, right? And they're also feeding back to their community. It's taking longer to get transplanted. We're not always getting that feedback directly, especially about UNOS. I'm not sure how educated that community is about the donation ecosystem, but they're definitely hearing about the underperformance, the mismanagement, that OPOs are not performing and allowing people to die in a very dangerous way. Because I think the one thing that is left out of that discussion when we look at the government saying that OPOs are underperforming, and they give data, so they'll say there were 5,000 deaths last year and only 20 organ donors, and so OPOs are wasting potential organs. The one thing that they don't go to the next step and explain is just because someone dies doesn't mean that that person is either medically suitable for donation means they don't have cancer or some infectious disease, or and that their organs are functioning at a healthy in a healthy way at the time that they die. But also, they're assuming that all of those people would say yes. And we know that that's not the case, is that not every person says yes to donation. Not every person has designated themselves a donor. And for the ones that haven't made that determination on their own, not all of their families will agree to donation, which takes us back to the importance of the Decision Project to educate communities and to spur communication within families about end of life decisions, hopefully to improve those outcomes.
Yeah. We're talking a lot about, uh, donations and mistrust in community, how to enhance it, how to improve it. You know, if we flip that and really begin to think about it, we do need more African Americans, Black folk, those persons of color engaged in inclusive participation in clinical trials so that we will be able to have better understanding of the science, if you will, that leads to the drug production or leads to other things with regard to learning more about the nature of transplants. So, can you speak to that side of the issue, Dr. Melanson and Dr. Ms. Ford?
Well, it's so funny, ironic that you should ask that question, uh, Reverend, because I was in a meeting just this week and I brought up to me a glaring omission, which is that in a lot of these committees and closed room discussions, oftentimes you do not have representation of people of color.
Right.
Even when people are saying we need diversity, we need someone to represent diversity. And the irony is the someone that normally represents diversity on these committees are white. Now, not that a white person cannot represent the needs of the community, but it just goes to show you the blind spot that many of these organizations have when there are so many well qualified, sometimes legendarily qualified, like one of the usual co hosts of this program, who has done more for increasing access to transplantation of people of color than any other single individual in this entire country. And
Mm,
sometimes when I bring his name up in some of these organizations, people are like, oh yeah, Dr. Calendar. And it's just, to me, it's very insulting because this is exactly the problem. And so what the way to address the issue that you bring up, which is a very, very real issue, Reverend Curry, is that those of us who can have a voice must shout from the rooftops and say, look, it's not appropriate to exclude minority voices from these rarefied rooms.
mm,
We must be included. And this concept of diversity, which I believe sometimes can be used to whitewash the problems. Because, like I said, oftentimes the person that's picked to be the voice of diversity is not a voice of diversity.
yeah.
So I think it is getting better, but just like we have seen affirmative action programs mostly benefit white women, we can start to see that this can also be an issue in these committees. Let me just say one last thing. Right now, and this is another issue I was going to ask Kenny about, so many black people have been literally flabbergasted that in the medical community we measured kidney function differently in black people than we did in others, and that this had an impact. I must tell you, I, for one, although I've worked in this area for decades, didn't realize that the impact on access to transplant was as great as it actually is. But it is. It is definitely has been a negative, has had a negative impact on access for African Americans. Now that the rules have changed, I must admit again, was surprised at the backlash of white people and white physicians in particular, people I've worked with for years, that are upset that Black people are now getting equitable access. I mean,
Mm-hmm.
we've got some big issues in this country, and I think the forces that have been unleashed by our former president has impacted us in healthcare. And I think we need to
Yeah.
be honest about that. The divisions that we see in every other aspect of American life is present in medicine as well. And I think we need to well discuss these things because it is impacting the health of individuals.
You know, it's
Yeah.
interesting. Go ahead, Brother Boyd.
I'm sorry, Reverend Curry. I just wanted to kind of, I think Dr. Melanson, who, along with Dr. Calendar, are two very influential people in my life professionally, is really humble and avoided mentioning himself in that point that he made earlier. But I think when talking about the absence of diversity in healthcare, we have to remember that without Dr. Calendar or Dr. Melanson present, how does that impact who gets on the list?
That's
Because
right.
the physician is making a decision and sets the tone for his program about how we're going to give access to our community. And I don't like to name institutions, so I won't. But let's just say that you work at a Beverly Hills hospital, you might not want to list Medicaid patients on your kidney list, right? And
Right.
so, how does that disadvantage that community if there's not representation? And then within my organization, the TDP, which is the Decision Project, is not a free initiative. And so without me in an executive role, where's that voice to say this is a meaningful, responsible way to allocate our resources? And so just to kind of amplify what Dr. Melanson was saying in terms of how diversity and that representation, when administered by organizations, needs to be done sincerely, and it needs to be sincere, right? It just can't be a checkbox that there was someone to represent diversity in the meeting. Diversity needs to be present itself,
Right.
not a representative.
Yeah, that's a hard thing.
Yes.
It's going to take more than just dialogue. It's going to have an action plan itself to begin to eradicate this, because on one hand, you have doctors that you say do no harm, right? But on the other hand, you inherently do harm due to structural racism, systemic oppression,
Yep.
uh, all of those sorts of things. So you're inherently conflicted. Not only to mention the fact that if we're all created in the image and likeness of God,
Mm.
and there's equity and equality and worth and value for all equally, then why is it that you see me the way that you do when I
Yeah.
move toward an equity space? Well, is it that you don't see me as equal and that you still see me as 3/5 of a person?
Mm.
So I raise that because this is a very serious issue. It,
Very.
it it doesn't matter whether it's kidney or pancreas or liver or heart or whatever it is. We have to have some understanding around this whole piece of transplantation. And I would love to hear more from our audience that's on Facebook and on YouTube. If you have questions, please put them in the chat. We'll get them up because we have some good stuff going on here. I would like to say this. I appreciate the work of Dr. Melanson and Dr. Clive Callender for what they do, and all of the other African American, those who are BIPOC. And we'll find that all of those persons of color, right, are, I'm sure, trying to help. How do we begin to have these difficult conversations that you spoke of, Dr. Melanson, that will deal with those particular issues? What does it look like?
Yes, yeah, and you know, again, Reverend Curry, you are so correct that these are real issues, really affected. I see, you know, this is not just theory. I see every day how this can negatively impact outcomes for African Americans and other minority patients, or even poor patients, and um, and and so it must be addressed. So the answer to your question is you've got to have these uncomfortable conversations. And you know, it's a shame that they have to be uncomfortable because you know, you're just discussing equitable access. You're discussing, like you said, we're all humans. So you should want to do right by all of the patients. You should want to give better access and provide better care and not just provide for the best insured and people that have the loudest voices. You should, but in reality, what happens is it's very difficult to make sure that these things occur. So I'll give you one example. I will make it my mission to have these difficult conversations with my team, which sometimes, honestly, turns into arguments because people feel very they when you bring race into the issue, when you bring structural racism, something that you've mentioned, when you bring these issues into discussions about access for healthcare, people become very defensive very quickly, right? Because again, they want to make it seem as if it's a fairy tale inside of hospitals that everybody is they leave their biases at the door, but this is just absolutely not the case. So yes, you have to have the uncomfortable conversations, including putting it on the agenda. So I will commonly put these things on the agenda in my committee assignments and make the discussion happen. And although they can be very uncomfortable, and turn into arguments like I said, um, over time people do become more cognizant. They may not agree, or they may not even publicly come to the same conclusions as like you or I would, but I see that the behavior is impacted. In other words, just having the conversations makes people act differently when these issues come up in the future. And that's my advice to, you know, because oftentimes I talk to younger people of color in medicine, and that's my advice to them, that you know, make people uncomfortable by having these conversations, because even if they argue you down, even if they are adamant that they and others did not behave in a prejudicial manner, you will affect their future behavior, and I've seen it firsthand. So the conversation itself is part of the treatment, Reverend.
Yeah, I think the conversation itself, and one of the most powerful ways is not only to hold it one on one, but to put it out there. It would be interesting to have this discussion that we're holding right now as an op-ed in the Post. Um,
Yeah,
Now,
absolutely.
because the Post has great readership, it's those that are going to really have to wrestle with these issues. And those op-eds are really one way. The other thing is we need to use more of our other sorts of media. I would say even in the media that is like the black print media in many neighborhoods in Baltimore and in DC, we need to make more awareness based pieces and then provide argument for and have the dialogue. Because if folk are not going to have discussion around the issues with John Hopkins and how they can be resolved, it's troubling that nobody's trying to address the issue, right? And we're just allowing it to persist when that's one of the better hospitals that one can go to, despite the fact of some of the other things that have happened. So, how do we, in order for us to get there, dialogue, yes, but who's putting together a strategic plan so that we can get this piece done, particularly with transplant. Any thoughts, Brother Boyd? You have some good strategies and tactics and all of those things.
So
But
yeah, I think the Decision Project brought to light some information that I want to believe Hopkins wasn't aware of. And so they committed resources to respond to that. And I think they're aware of how the community views them and are attentive to that. But I think that they suffer from, I think, people just having an ingrained mistrust of the hospital. It is
yeah,
passed along the same way that we pass along to our children other things that are systemic, right? And so it is going to take a while, and a lot of positive stories of people being treated well at Hopkins or receiving transplant at Hopkins or Hopkins joining in activities that give back to the community, whether there's some of the events that the TDP is facilitating with food drives and healthcare screening, but rehabbing their relationship with the community is something that is going to take a generation, to be honest. I'm no expert. I'm not an epidemiologist. I'm not a social specialist, but I can tell you that it's the same way with changing attitudes around donation. It's not a weekend engagement. It's not a season or a spring engagement. It is proving that you are willing to be present for an extended period of time so that people can see that you mean what you say in terms of your being a part of the community and having the community's best interests at mind.
yeah, yeah. Dr. Melanson, any further thoughts?
Well, I am actually intimately aware of a lot of the efforts that the Hopkins organization has made. And one of their main efforts is really just to become more diverse. And in their efforts to be more diverse, again, just getting those voices to be sitting at the table makes them on every level, from the way their pediatricians interact with children in the neighborhood, their admissions of students, medical students, residents, their outreach into the community around Hopkins, which is a very much a diverse, heavily minority community. All of these efforts, I think, have garnered some positive reverberations in the community. But Kenny is right. I mean, when you have generations of issues, it takes a long time to change perceptions in the community. And I've seen the same thing in other areas in healthcare, that beating your head against the wall, which it can feel like when you're dealing with some of these intractable problems. It feels like you're not getting anywhere. But one of the reasons why I have so much respect for Dr. Callender is, in my career, from the beginning of my career to where I am now, I've seen the change that he's made in the transplant community. Yeah. And I think that this most recent thing with the glomerular filtration rate being race neutral, those arguments really started with Dr. Callender back in the 1970s. And they're coming to fruit today. So yeah, you got to be willing to fight the fight for a long time. This is not just a simply go to one committee and make some noise. You've got to be willing to fight this fight for many years. And I've kind of gone into that stream created by people like Dr. Callender. But we are making some headway, right now. And so getting to your point, Reverend Curry, how do you make a change? Well, you have to find common cause. Okay. So right now there's a push for more live donation in transplant community. And the group that has the biggest problem are actually our people, the African Americans. So the common cause is, when you get more live donors, you get better access, not just for the people that get transplanted, but everybody moves up on the list as a result of that. So there is common cause to get more African American live donors. So we are working with UNOS and HRSA and CMS and all of these governmental agencies to try to make that a reality. And I think that's really where, again, a lesson learned well from Dr. Callender, because he used the civil rights movement as the modus operandi for MOTEP, the organization that he founded. And that's what the civil rights movement did, right? One of the, you're a man of the cloth, and the SCLC and Reverend Martin Luther King, they utilize media to make their arguments. There was no point to have a lot of these interactions if they were not going to reach the masses, right? People in Alabama and Mississippi and Louisiana didn't care nothing about Black people getting their heads bashed in. It needed to be nationalized, right? And so in much the same way, these arguments, like you said, we need to make sure that when we have these problems, we alert everybody. I read an article. I don't know if you saw this article, but there was an article in the New York Times just over a week ago where this lady was dying after her second heart transplant. And that got a lot of coverage. And I think it was a good story. However, this is a very privileged, well-off writer who lived almost 30 years after transplant. I can guarantee you there's a lot of Black people that would have never gotten that first heart, let alone the second heart. This woman is complaining from a place of absolute elite privilege. And we have people that can't even get in the door. So you are so correct, Reverend. We need to write these articles, and we need to make sure that the Post and the New York Times gives them coverage like they gave this lady coverage.
Absolutely.
And just to amplify something that Dr. Melancon said, he made that argument in living donation, but I think the same argument can be applied to how we invest in changing the attitudes amongst minorities with deceased donation. Because we know that our data shows us that a majority of non-minorities are already registered donors. And so even if you have a significant percentage increase in that population, it is not as impactful as even a 10% shift in the number of minority people who choose to be donors, because there is that gap will be closed by increasing minority donation. It is the best opportunity to close that gap in wait times and deaths on the wait list is to increase minority donation.
Wow, that's a powerful statement, and we've had a great show. I don't see any questions in the chat, but I think that our audience is definitely listening and taking in what you said. And I challenge each and every one to make sure that we get involved in the writing of op-eds, and we get involved in the sharing of our views, and we get involved in having dinners across difference. And when we're able to do things like that, we'll be those that will be able to help educate. For many folk are destroyed for the lack of knowledge. And so we are really grateful for this presentation today. It went there and it went deep. And I'm thankful to you, Mr. Boyd, for all that you've done with Infinite Legacy and the presentation. And of course, Dr. Melancon, and in his absence, the Venerable Clive Callender, Dr. Clive Callender, a great leader. And we just want to say thank you. And we want you to know that you're always welcome to engage us at Kidney Talks with the Ron and Joy Paul Kidney Center. I'm Kendrick Curry with Dr. Joseph Keith Melancon and Mr. Kenny Boyd, and we are thankful for this opportunity to share with you today. So we look forward to having another great time when you see us again in Kidney Talks. Take care and be well. Bye for now.